My name is Anne Langkilde. I'm a PhD student at the Clinical Research Center at Hvidovre Hospital. And I'll present the study, Increased plasma suPAR level is a risk marker of respiratory cancer in initially cancer-free individuals. The background of the study is that low-grade inflammation is a risk factor for a variety of diseases such as cardiovascular diseases, diabetes, cancer, and ICU, a lot we've heard today. Low-grade inflammation is not yet defined, but it's characterized by slightly elevated levels of inflammatory mediators such as CRP, leukocyte numbers, TNF-alpha, and maybe suPAR. This study was published in 2010, where it was found that increased suPAR levels were significantly associated with development of cardiovascular diseases, diabetes, overall mortality, and overall cancer in apparently healthy individuals from the general population. Moreover, in 2008 and 2009, it was published that the inflammatory markers, CRP and YKL-40, were significantly associated with development of respiratory cancer and gastrointestinal cancer, respectively, in the general population as well. And this led us to investigate whether the increased suPAR levels found in the study from Journal of Internal Medicine were mostly associated with some types of cancers more than others. So, we divided the cancer cases into 3 groups: respiratory, gastrointestinal, and other types of cancer. And of course, we only had 372 cancer cases, so more elaborate subgroup analysis was not possible to perform. And the design of the study is based on the Monica 10 study, which we've heard about before here. And individuals from the Copenhagen County, apparently healthy, age 41, 51, 61, and 71 at baseline, were examined in 92-94. And these individuals were followed using national registers until the end of 2006. And in this study, we only included individuals with a suPAR measurement at baseline and with no present or previous cancer at baseline. We analyzed the endpoint as competing endpoints, and that is that if you have if your first cancer during follow-up is respiratory, and you have a gastrointestinal cancer later on, you're only included in the analysis for the respiratory cancer. So to put it simply, we have a suPAR level at baseline in 92 to 94, and then we follow the patients or individuals, they're not patients, until 2006 and investigate what the initial suPAR measurement signifies for the diagnosis they have during this time period. And we investigated this in Cox regression analysis on the left, and we performed a multivariate Cox regression analysis adjusted for established risk factors such as sex, age, gender, sex, age, BMI, smoking, and alcohol consumption. And we also investigated the other inflammatory markers of this cohort, CRP and leukocyte numbers. And as seen here, increased suPAR levels were significantly associated with development of respiratory cancer during follow-up. Increased CRP levels were not significantly associated with respiratory cancer diagnosis during follow-up, whereas increased leukocyte numbers were significantly associated with respiratory cancer during follow-up. None of the inflammatory markers were significantly associated with GI cancer during follow-up, whereas only increased suPAR levels were significantly associated with development of other types of cancer during follow-up. So we also wanted to investigate what the levels of the other inflammatory markers meant in this setting. So we performed a mutually adjusted analysis on the right It's still adjusted for the established risk factors, but it also takes the level of the other inflammatory markers into account. And as seen, increased suPAR levels are still significantly associated with respiratory cancer development when CRP levels and leukocyte numbers are taken into account, whereas neither CRP nor leukocyte numbers are significantly associated with respiratory cancer development when the suPAR level is taken into account. Increased suPAR levels were also still significantly associated with other types of cancer development during follow-up when CRP levels and leukocyte numbers were taken into account. So we wanted to look at this further since, and smoking is the #1 cause of respiratory cancer. So and of course we adjust for smoking, but we want to look at this only in smokers. So we made a model, a cumulative incidence model of respiratory cancer among current smokers. We divided the smokers into sex and age-specific suPAR quartiles, since we know that suPAR is higher in women than men, and suPAR increase with age. And as we've seen in the other studies presented here, it's pretty dangerous to be in the 4th quartile. It had a much higher cumulative incidence of respiratory cancer than the other suPAR quartiles. And one could wonder whether this reflects that it's the heavy smokers that are present in the highest suPAR quartile. So we investigated the association between suPAR and pack years among current smokers. And this is a model demonstrating the age-specific pack years for current smokers and the suPAR level. And then seen from these figures, it's the smoking, the tobacco consumption does not explain the suPAR levels. So there must be something more into this. Pack years here is calculated as tobacco consumption per day times the duration of smoking. Yeah. So conclusions and perspectives of this study is that we found that increased suPAR levels were independently of established risk factors associated with respiratory cancer and other types of cancer, but not gastrointestinal cancer. And this is in a period of 14 years. And this might indicate that there could be different etiologies underlying the various cancer groups. But one should be very careful saying that, because the respiratory cancer group is very homogeneous, and the vast majority of cancer cases in this group is lung and bronchus cancer, whereas the gastrointestinal cancer group include cancers that are both colorectal and from the liver and pancreatic with very different etiologies. And of course, the other types of cancer group is the most heterogeneous of all the groups. We tried to perform subgroup analysis, but due to the limited amount of cases, we could not make this more elaborate. So it would be very interesting to look in larger population-based studies to be able to make more subgroup-specific analysis, because it seems like something is hiding in the suPAR and other type of cancer group. But what I find very interesting is that here it somehow seems like suPAR somehow reflects smoking-induced pathology, and it's not explained by the pack years in this study. And well, it's a tempting thought to, can we use suPAR to investigate who can smoke and who cannot smoke? But you don't know when your suPAR starts to rise, and you don't know if you've bumped into the stop sign. And yeah, so that was it. I would like to thank the co-authors of this paper. I just sent in the proof last week, so it should be out very soon. And thank you for your attention.